Welcome, everyone, to today's panel discussion, Care at Home, How Remote Programs Benefit Patient Outcomes and Access and Reduce Costs. I am Brian Zimmerman, today's moderator. On behalf of Becker's Healthcare, thank you for joining us. So before we begin, I'm just going to walk through some housekeeping instructions. You can submit any questions you have throughout the conversation here by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If at any time you have trouble with the audio or video, try refreshing your browser. You can then also submit any technical questions into the Q&A box. We've got folks on the back end who can help you out there. Lastly, I do want to thank Bioformis for sponsoring today's session. Bioformis is a global health technology company that is focused on transforming patient health through the delivery of personalized predictive care. We're going to dive in here and begin the standard way with some introductions. So I'm going to tap on each of our panelists here to share a little bit about their professional background, their organizations, and the like. Chris, I'm going to throw it to you to start.
Thanks, Brian, and thanks to Becker's Healthcare for having us. My name's Chris DeFlitch. I'm an emergency physician. I serve primarily as the Vice President and Chief Medical Information Officer at Penn State Health. It's a multi-hospital system in Pennsylvania. I also am a professor in the College of Medicine at Penn State University, and happy to talk a little bit about our journey through remote care.
Looking forward to hearing more about that journey, Chris. Thanks for being here. Raj, I'm going to throw it to you now.
Hi, thank you to Becker's. So I'm Raj Krishnamurthy. I'm an internal medicine physician and the Chief Clinical Transformation Officer and VP for Population Health at University of Chicago Health System. So our system is comprised of an academic facility on the south side of Chicago, as well as an affiliation with Advent Health in the Great Lakes area, where we have 4 hospitals on the south and west side and a community hospital system. Look forward to conversation.
Yeah, we're going to get to it shortly. Thank you, Raj. Beth, throwing it to you.
Hi, everybody. Good afternoon. My name is Beth Kushner. I'm a practicing emergency physician and also the Chief Medical Information Officer for St. Joseph's Health. We're a small to medium-sized healthcare organization in northern New Jersey, just outside New York City. We focus in on the vulnerable and underserved population, and that's really our focus for our healthcare system.
Excellent. I appreciate having your perspective here, Beth. And Sandeep, let's round us off on these intros here.
Thanks again, everyone. This is Sandeep. I'm one of the medical directors here at Bioformis, as well as the VP of Clinical Strategy and Partnerships. So I spent the last 10 years helping to build some of the digital solutions that are being used today across various different health systems. Started one of the first RPM CHF admission companies about 10 years ago, and then went on to build clinical decision tools leveraging AI solutions, and then right before coming to Bioformis, built large-scale virtual delivery platforms that are being used at large health systems across the U.S. In terms of what my role here at Bioformis, Bioformis is kind of a unique company that combines the ability to connect, configure, and personalize care based on both virtual and inpatient care options. And we do that through a combination of technology that we enable services to span the continuum of care using dynamic care pathways designed to personalize and deliver individualized care using data-driven interventions for every patient that we help care for.
Thank you, Sandeep. And I want to begin here by sort of getting sort of an assessment, perhaps, on how remote care, remote patient monitoring, hospital at home programs, all this sort of stuff has really evolved over time. It's certainly skyrocketed in sort of utilization and sort of adoption. So I want to get some sort of high level comments here about how it's evolved. What is the current state of home-based care delivery? Sandeep, I want to begin with you. I think your perspective would be interesting to have here, just based on how you've seen some of these solutions evolved and what you're seeing even among some of your partners out there.
Yeah, no, I think it's great, right? In terms of when we started about 10 years ago using single point data solutions to help understand what was happening clinically with folks that weren't in front of you, right? To help then to manage those patients as best we could to help avoid readmissions back in the day, right? And then as things have progressed, the need for using these kind of remote technologies, not only just to do telehealth, right? Just a video call is kind of what people think of when you think of remote care or telehealth in general, but applying data elements to using to that type of interface to actually help understand what was happening with patients, I think is where things have evolved to. And COVID helped to accelerate a lot of that learning, both on the patient side as well as the clinician side, and what could be done safely and effectively to deliver the care needed, not just to kind of do a video consult, but actually help understand what was clinically happening with patients when they were no longer in front of you. And a lot of the barriers and challenges that existed in terms of adoption and getting buy-in from both the providers and patients to accept and deliver this type of service, I think has changed a lot. So in terms of what my personal view on the space, it kind of shifted from, hey, could we do this? Yes, I think we could do some of it. And then all the way to more complex care now, especially as hospital home programs have started to scale and be built out. Delivering complex care into the home is now where we're seeing more of those trends go.
And before we work in some more perspectives here, Sandeep, can you just talk even a little bit more about just how big a deal it is that the buy-in component here, that patients and sort of providers are also more ready to embrace this kind of stuff? Can you talk about how that has really been an accelerant here? Just get some more commentary there.
Yeah, it's especially on the, when you think about on the provider side, right? People are trained when you go through, med school, fellowship, et cetera, to how to physically examine a patient. When someone comes to see you, how do you evaluate those patients? Especially, Chris, Beth, and Roger, and you see patients today, it's still challenging sometimes to move away from that, physical contact, but how do you have proxies for that experience? And so I think that's one area where a lot of doctors, providers in general, nurses as well, learned a lot about how you can understand what was happening with patients. And, programs are being built to actually train physicians and nurses on how to deliver care remotely. And patients, obviously are more accepting now because they saw the need. And I think patients in general prefer to have the home as a site of care as opposed to being in the hospital if it was avoidable. And I think, the shift also from episodic data, meaning like, once a day blood pressure or, weight data, to more kind of continuous monitoring that's now made possible, that allows the comfort level, right, that patients have of understanding, hey, you know what, this is not me just being alone. I now have a whole team that's looking after me. And then on the provider side, using those same data points now, but understanding how to use them effectively. So I can, scale access to these type. And I know we'll get into the details later here, but hopefully understanding how, from a clinician's perspective, using these data points now in a workflow centric model that allows me to still do what I need to do and get the right information in front of me to deliver the appropriate care to the patient. So I think those are the three shifts that we saw, from episodic to continuous data, as well as the acceptance of patients to understand now that there is a lot of people that are supporting my care, even though I don't see them physically.
Thank you, Sandeep. I appreciate you setting the stage there. And I do want to dive in and get into some of the specifics about, what St. Joseph's is doing, Penn State Health is doing, UChicago Medicine is doing, but want to open it up here also to get some more high-level comments, hooking on, adding to what Sandeep said, or what is something that maybe we should also reemphasize as well. Raj, any thoughts there?
I think I would echo a lot of what Sandeep's comments. I think a lot of this was culture change on the part, forced culture change by the pandemic. But then, because it isn't a skill set we learned in med school that we've had comfort level with, and I think the paradigm has always been the laying on of hands and the whole direct examination as part of that history and physical. And I think both patients and providers being willing to accept this as a good way and a safe way to deliver care. And I think that culture change has been the big accelerant to this work, that we can do it, we can support it, and we can drive better outcomes that are hopefully more convenient and appropriate and at lower cost and disruption for patients' lives.
What would you say to like sort of the conception of what's possible has changed mid-COVID? What health systems are actually capable of doing with technology that has changed? Is that correct, Raj?
I think that's fair, both in adoption of telemedicine. I mean, we continue to see about 10-11% of our visits are in telemedicine. So again, it's that extending the reach and then continuing to add the technologic aspects to make this the even between visit care more efficient, productive, and driving towards better health outcomes and equitable outcomes too.
Absolutely. Thank you. Chris, let's get some thoughts from you now. Then Beth, we'll check in with you and I'll have another question for you as well.
Yeah. So it's been interesting. I think we all sort of in our roles as thought leaders in healthcare IT would have said 5 years ago, telehealth's going to have some role inside of here. Remote patient monitoring is going to have some role inside of here. And I think at least we at Penn State, we're struggling to find out what's the why. Why are we doing this, right? We got the technology that's possible. And so I was thinking things in terms of people, process, and technology, right? We have the technology. It's not hard. People and processes, the whys really weren't there. Pandemic really laid the groundwork for us to be able to be allowed to do some of this stuff. So like everybody else, we went from very little remote visits to, at some points, almost all of our visits were completely remote. And then we started iterating on, was it just about the visits? Can we have group activities a little bit differently? Can we connect to the patients in a different way? Can we connect to the families and decision-making in a different way? And so I think then we think about our own business, right? So if you think about it from a business model perspective, we've got the business to business opportunities. We're providing remote care to other community hospitals and virtual ICUs now, where we never thought about doing that before. We're direct to consumer in many ways with secure texting, with patients, remote care at home. So patients come to my emergency department and I see them. We screen everybody for potential hospital at home activities. We have some triggers in the electronic record that allows us to say, oh yeah, a high likely candidate related to it. And then, we're doing that. We're doing ED to sniff directly for home related stuff. So we're trying to find what problem we're trying to solve as opposed to where before we're doing it. And so I think for me, it's the why. If you can answer the why question, and then does your culture fit, Raj? You're right on. And then the people and process stuff. Technology is coming along. We're fine with the technology piece, but the culture, people, and process, and be able to answer the why, I think is really where the question lies.
Real focus on being intentional there, not just rolling out technology for technology's sake, but leveraging it to solve specific challenges. Correct?
That's right.
Beth, let's get some comments on you. Just any additions? I know they your fellow panelists here covered a lot, but anything to add, and then I'll have another question for you too.
I think one of the biggest things that I saw for providers to really believe and start the adoption process is the information that we're getting reliable? How do you make the people, the process, the technology, how do you have that sense of seeing is believing? And for a lot of our providers, they needed to understand that telemedicine can provide a function in the care of their patient. They need to see that remote patient monitoring has a role and it's reliable, it's consistent. And for my providers, they need to make sure that there's equitable, there's the ability for everybody to be able to have it. And so it's not just for a select group of patients, it can be used in different venues of care. And really taking the why and taking it and looking at it in different venues of care. Back when I thought about medicine, I was really excited about the splashy parts of medicine, but truly care coordination is one of the most exciting things. And being able to take a patient and slot them into the right avenue of care is really exciting. And remote patient monitoring and all of these different tools, leveraging technology really helps care coordination go over the hump into something that can be really exciting and it can be really different and it really can capture residents and young doctors and even physicians who've been in the game for a while and say, wow, look at the change that we made. So I think it's a really great from a large view.
Beth, I think you're right on. It's interesting. I think it's not only the we trust the data. I think it's how the data is presented to us and what's the volume look like, right? Do I really want to see every pulse that comes out of everybody? Do I want somebody to have a monitor on them to see, strings of data that are like, gigabytes long? No, put it in context to me and what I need, right? So we can have the privilege of providing care at home, but from a remote sense. Now, the context is really where it comes into, right? We don't want all those wearables. That's way too much for anybody to even think about, right? But to have it for something that's of value, put it in context to me as a cardiologist, or me as a dermatologist, or me as an ophthalmologist is where we got to get to.
Absolutely.
Thank you, Chris. And something that struck me, Beth, about your comments too, was the The idea of care coordination being really important here. I think it's not hard for, it's not an uncommon experience for patients to feel adrift
Absolutely.
in the healthcare system. So it's like it's hard to overstate just how much of a game changer really nailing care coordination would be for the industry, right?
Yeah, absolutely.
And Beth, let's dive in here and get into some of the specifics you're all doing a little bit more and zero in on that why that's come up a couple of times. So can you talk about, Beth, like sort of what criteria your organization considers when trying to deploy or scale remote care programs, and then dive right into and share some of the outcomes or results you've seen in terms of how this affects patients and staff?
Awesome. So I would say that we focused in on certain disease types. There's a million patients and a million different things you could do. And the way for us to organize and how we decided to do a rollout is based on different disease states. So CHF is always a hot topic. Readmissions are really important and they happen frequently. And we want to pick disease states that are lifelong, that affect patients on their day-to-day interactions, even from meal to meal per se. And so we focused in on a couple disease types, and not just those who are complex older. We also have pediatric nephrology patients as well. And the third group that we really focus in on is maternal hypertension. And without casting too large of a net too quickly, because once again, people process change, all these things we have to be super sensitive towards. We want to focus in and really decide on what would be the most meaningful change for our patients. Like I said before, I have an underserved, vulnerable community. And one of the ways that we start to screen our patients is to have the conversation of, do they understand the why? Do they see the value in this? And are they going to be able to participate and really be able to close the loop on the back end and utilize the product? Or are we going to be spinning our wheels? And I think when screening the patient, you not only need to have the right product for the right disease state, you need to have the right patient in that. It's almost a triangle. And that's really how we started to implement our programs.
Thank you. Some really helpful stuff there. Raj, what would you say? Some similarities there between how your organization sort of assessed this? What else might be different?
So I think similar, back to the why. And for us around this time, there's been a lot of, similar to Beth, focus on disparities and understanding that. So more recently, over the last few years, we've attached a disparity lens to a lot of our metrics, especially in ambulatory, but inpatient and outpatient, all of our internal clinical excellence scorecard metrics, we have a disparity lens on. One of the areas where there was the largest disparity lens is hypertension. And with that, again, the maternal mortality related to hypertension. And so that's where we've started in trying to reduce disparities and using our remote patient monitoring, recognizing also the challenges of coming back and forth to the hospital for new moms, for moms with hypertension, pregnant moms, or women who are pregnant, trying to identify those opportunities. So that's in part where we started has been around hypertension, and it's relatively more simple technology to implement, and setting up a program with digital navigators, given the population we're trying to attract, and supporting that through a team of population health nurses who also receive that information, digest it, and pass along those things that only need to be passed on. So I think all that process piece, how do we make it sticky? How do we decrease the friction for our patients? And really using that disparity lens to try to identify populations at risk that we really want to leverage the technology to support.
You can share there, Raj, too, in terms of what that impact has meant for patients and those nurses too who are involved in those programs. Yep.
I'm sorry, was there a question?
Yeah, can you share anything about what the results have been, what that experience has been like for patients and those nurses?
Sure. I can share on the hypertension. So we've targeted disadvantaged populations in particular. And we noticed our Black and Latinx populations had 10% lower hypertension control rates than our white populations in our South Side academic clinic. And that's where we started our program. And we've been able to show a 3-4 point reduction in that disparity in hypertension control rates. I have less the data, but on maternal outcomes, but we have seen better control in our pregnant populations with hypertensions, more compliance and follow through, and better term deliveries. And then the recognition, I think postpartum also, of the continuation of hypertension even afterwards, and getting women into control and into a care delivery program.
Thank you, Raj. Appreciate you sharing that. Chris, let's get some thoughts from you now, some information from you, and then Sandeep, I'm going to check in with you.
Yeah, thanks. Just like was said here before, I think that for us, it's the value add. I espouse very much to a lean type thinking as to, can you get rid of waste, and can you make it most effective and efficient for the people who that we're serving as physicians, our patients, but we also serve the physicians, the nurses, the techs. And so when I think about how we go ahead and do these remote care type programs, think about the model and how it's really changing. So we did grow up. Some of us have been doing emergency medicine for 25 plus years, right? And we're taught in a certain way, and we're in a certain way. But is that really what people need, right? We only get a chance to interact with patients a few hours in a year, right? And that's really not necessarily the model that we should be thinking about, in my opinion. We should really be thinking about, how do you continuously manage patients over a period of time? And it doesn't always need to be the physician, okay? It can be a nurse, it can be a care coordinator, it can be a diabetic educator. I mean, they're a heck of a lot better at doing this stuff than I do. And we can use technology to enable those things. So at Penn State Health, it's exactly what we're doing. So we don't have enough beds for all the patients who want to get taken care of at Penn State. We're privileged to be in that situation. But what patients don't want to be in the hospital, they want to be at home. So why not help them do that? And so that's where we partner with the hospital at home activities. You've got to coordinate it very well, but it's much more efficient and effective for that patient to be better in their own home when that's possible. Same way with the SNFs. So we've extended it to skilled nursing, which the beds are really shrinking all over the place, especially in Pennsylvania, in my experience. And there's still that need for that population. So we're growing that remotely. Managing, like, CHF, it's a classic one. We're all doing that sort of stuff. We have a virtual paramedic program where we send the medics out to the clinic or out to their homes, and using some of our community-based programs where they're the hands-on keyboard, if you will, at the patient. So they don't need to drive 50 miles to come see me in my heart failure clinic. It's adding those values. We've taken the intermittent video visits and made hybrid visits. So now, does a patient really need to do all that demographic stuff or patient questionnaires and things like that in the clinic? No, not really. They could complete it on their portal. They could remotely register. And really the only time they need to be here is for me to actually do the physical exam or for me to do a procedure, right? So we're limited in face time. We did that during the pandemic, especially with our transplant population, because they're at higher risk in that scenario. We call them hybrid visits. And we see more and more people starting to do these hybrid visits. We're changing the model. And I think that's really what we're coming down to, is we're asking why, and then taking the opportunity to say, why not in some scenarios. So that's just a couple of things that we're doing here at Penn State Health.
Yeah, thank you, Chris. And I think something you pointed out there that is important to acknowledge too is sort of the limited beds you mentioned in nursing facilities and things of that nature. Like, there are some big time challenges in healthcare that this technology has the potential to help mitigate and solve.
Even specialists, right? So how many pediatric neurologists are there out there? Try and find one, right? So we're doing a lot of our visits, to our clinics, the at-need population, whether in a community hospital or where they're in a underserved area. we're taking that remote activity to them. So they're able to see that pediatric neurologist or that pediatric endocrinologist or that neurosurgeon or whatever it happens to be. And they don't have to do that. So they're getting the highest level of care that Penn State Health provides, but in a remote sense.
Yeah, some great points. Thanks for sharing that, Chris. Sandeep, give you some space now to sort of react to what you've heard and share a bit of your perspective.
Yeah, no, I think, Chris, Beth, and Raj touched on all of this, right? It's, what we see across all of our kind of, we have a different perspective, right? Because we work with organizations in different capability, if you will, like Chris is describing a very robust, well thought out, built out program. And there's others that are just getting started on the trajectory. So we see that entire continuum on folks that are on our platform. And the idea that you can transition from acute, post-acute chronic disease management all on a seamless experience is what we're seeing that patients prefer, right? Because what typically used to happen, right? You used to go see your doctor, in an inpatient setting or a facility, be discharged home, and then be introduced to an RPM program for 30, 60 days, and then you have another kind of chronic disease program. So it was kind of a broken experience, right? So what makes Bioformus a little unique in what we're hearing from both patients and providers is having that seamless experience where from a provider standpoint, you can seamlessly transition folks as they improve that care and the trajectory is more long-term. And then patients, they understand that having a common interface that understands that can flex with them, right? To be able to go from a acute 4 to 5 day, in-home episode, and then transition seamlessly into a 30-day post-acute program. And then as Chris described, long-terms like CHF, think of GDMP programs where you can automate the titration and the medication management. So that's really this shift from, remote patient monitoring to remote patient management is what we're seeing kind of from a behind the scenes perspective. And this coordination of care moving to this hybrid model that Chris described, right? It's no longer just about the devices that I'm monitoring for patients, but actually helping to coordinate some of the in-home services as well. Things like, mobile phlebotomy, imaging, DME. So having that ability to have your patient's experience be central to them, but giving your care team the flexibility to adjust your programs to fit what the patients need across that continuum.
Thank you, Sandeep. And I want to move now to really focusing on sort of execution here in terms of how you go about introducing these programs, rolling them out, because even with a good buy-in, there's still going to be challenges and barriers just from an execution standpoint. So I wanted to hear a little bit about some of the barriers you all have encountered, and maybe any best practices or any advice you can give folks in terms of overcoming those barriers. I want to hear obviously what's happening at some specific organizations, but Sandeep, what is your just reaction to that question that I just posed?
Yeah, I think, and you have a good representation here on the panel, right? It really depends on the level of sophistication experience that these institutions have had with rolling out these type of programs. Like the way Chris is describing about his model is very unique in the sense that they understand how to leverage the community paramedicines, they understand how to leverage, in-home service models that require care coordination pieces, but there's others that are just getting started. And it ultimately comes down to everything that the folks here described, which is, understanding who the folks are, understanding the processes, and then scaling these type of programs. And I think the biggest challenge at the early stages of these, when you're starting to launch these, is about patient identification and patient selection, right? How do you make sure that the right type of care can map the needs? And so Chris mentioned they have some sort of a system in their EMR, but where a lot of these programs struggle is, first is making sure that we're identifying the right patients and that we're mapping the right care pathways to deliver this care remotely, and then getting the buy-in. So sometimes, I don't know, Chris, if this has happened in your institution, but folks forget that there are these virtual beds available and they don't, enroll patients into them or admit them into them because it's such a new concept, right? So those are the kind of things it's not the technology, it's more about understanding that this is a safe way of delivering care.
Getting that messaging out, right? Just making sure people know it, maybe saying it a few times, letting folks know that this is an opportunity.
And actually, one other thing, Brian, is like sometimes just because everyone's staff, resource, and constrained right now, you may actually have to dedicate a full-time resource that we kind of, seen that are successful programs where it's an outside resource that comes in and helps with the patient selection onboarding because the staff, your internal staff, is just overwhelmed and busy sometimes as well.
Yeah, you're talking about the people and the process, right? And you've got the why, and conceptually, I think physicians, nurses, and APPs can get that concept, but it's sometimes more work for them to do that, right? And so we've got to value the work that's associated with it. So talk a little bit about Penn State Health. We actually stood up a whole different component of our health system for virtual care. So it's just, and it sits like every one of our hospitals does. It's just virtual care. And so, we've got a VP over top of that. We've got medical directors of each one of those. During the pandemic, it was me and a VP and, bootstrapping and busting our butt, right? Like we all did at the beginning of it. But then you see the value and all of a sudden you get, oh, okay, here's a good partner that is thinking about things in a different way. How about we do that? So there's a couple of things. You said barriers, dollars, that's the biggest one. How do you get paid for these things? How do you support something? It could be the absolute right thing to do, but if there's no thought process on how this is going to be at least a break-even proposition, mostly a profitable proposition, then you can do that. It's out there. The finances are there if you look at them and pay attention to it. The resources to do it. I think the people that you have it. And it's not just named people. It's passionate people. It's people who really want to get out of bed and do this. So for me, as the Chief Medical Information Officer of Penn State Health, I've got 47 hats I'm wearing. So to start it off, yep, absolutely. I could be that cheerleader. I could get it fired up. I could bring the right partners in, but I've got to be able to mentor somebody to hand those things off to, and we do that. So a virtual primary care program we have with a medical director, a virtual ICU program we have with a medical director, a hospital home program we have with a medical director, and a number of nurses that are providing all this remote care activity. So not to be understated, and it took us a while to get it right. I mean, if you were to talk to me before the pandemic, we're struggling to get people to do a video visit. And now we're in a different place because people saw the art of the possible during the pandemic. And now they're saying, oh, why not? Maybe we should. I think we can, as opposed to no, not me, maybe later. To get a little bit more formal, I think people have to have a good OCM activity, organizational change management function. So where your leverage points are in your organization and leverage and methodology associated with that from a leadership perspective. But nothing beats the passion of the individuals who are out there boots on the ground.
Thank you, Chris. So some important barriers there, resources, finances, other operational challenges. Raj, let's hear from you now in terms of what you've experienced, what you might add. Then Beth will turn to you, and I'll have a question for you as well.
And I'll say for U Chicago Medicine, I think we're probably earlier on in our journey than where Chris and Penn State are. I think some additional things and thinking of also how we deployed and where we started around hypertension and thinking about more vulnerable populations is to think about a digital navigator. So at point of entry into the system, who's that digital navigator that helps the patient either set up on their smartphone, the app to collect information, who understands if it's a remote patient blood pressure device, how to use that, how to record that, how to connect to the internet, whatever pieces that they need to buy in and feel comfortable with whatever technology or support we're deploying to their home. So you want to decrease as much of that friction. And I think that was really early on an important part, and still is, that we capture patients, we enroll patients during their clinic visit, and then we follow through remotely in between visits. So that was one point. I think we also connected the program to our community health worker program. So in some circumstances where there was just additional need, there's the ability to do home visits for patients to have support and advocacy on their level that can help navigate the technology or whatever they needed. And even sometimes a home visit that was needed in support, we were able to do that. And then I think similar issues that Chris talked about, what's the ongoing financial support? I think for us, a choice is, do we bill these visits or not? I think we're still, especially given our focus around disparities, not wanting to create barriers for patients signing on and additional cost. What does that look like? I think we're still grappling a bit with that ROI, but as we look to scale beyond hypertension and beyond the current programs that we have going on, I think that is more important an issue around the support and the ongoing deployment and expansion of these programs.
Yeah, and I imagine those are questions a lot of organizations are wrestling with too, in terms of how do you communicate the ROI here when it's just it might your priorities and what you need to do for your community are clear, but how do you sort of figure this out financially? It's some really important points. Beth, what would you add here?
So I think infrastructure is always important. You have to have a good pathway, a good workflow. Whenever we try to implement something new, I think my colleagues get really tired of me saying, well, what's the workflow? What's our workflow? What's our workflow? But it's really important for that to have a solid foundation. Otherwise, when you implement new programs, it becomes really hard. And it seems like sometimes some of the details get lost. And I think with virtual programs, I can't wait in 5 years to be like Chris and say, when I started, it was a little bit of a mess, but today I have a medical director of a virtual hospital. So I look forward to that day, and I'll call you Chris, just so I can let you know. But I think that
we're all learning about this together. It's
exactly.
You know, I mean, we've plowed some road. Don't get me wrong. I think we're doing some really good stuff, but we're learning every single day. And I think that's the idea, right? You learn a lot from the people that are actually doing it. And then if you listen, you're probably going to be better off.
Exactly. So I think having people who are dedicated to that venue of care, and it being a virtual venue of care, but that's their passion, that's their focus. So I think that that's a really important conversation, important point to make it successful. And lastly, I think also the ROI. When I try to speak to some of my patients, or I know my colleagues speak to a patient who's on a pretty fixed income, and there's a required copay for some of the items, it's a hard conversation to have and say, I think this is going to prevent you from being admitted. It's a much more powerful conversation if you're able to say, I know that this is going to prevent an admission in the future. But if your patient's on a fixed income, how do you offset that, or how do you make it worth their very, very, very valuable income to say, I think that this is going to be, this is going to be a game changer for you. This is how we're going to coordinate your care. So I think for a variety of reasons, there's some hurdles. And I think that as we get better at it, we're going to have more, case studies and use cases. And we're able to say, look what happened with Mrs. Jones. And this is incredible. And Mrs. Jones, she has really bad CHF too, but look at the life that she's living. And she hasn't been in the hospital for 2 years, and we'll be able to show the value. So I look forward to the day where we have so much more data to get to talk about that.
Beth, and this conversation is flying by. And before we get to closing thoughts, though, I figured give each of you some space here to talk about really the potential of these programs to transform care in a number of different ways, in terms of potentially improving health equity, amplifying the workforce, while also hopefully reducing some of the burden that's on them by amplifying the reach of certain elements of care. So just let's take a moment, each of you. I'm going to tap on each of you to sort of weigh in here and talk about the potential transformative nature of these programs and technology. Beth, we can begin with you.
I think it's limitless. It's incredible the information that we're able to get. And through AI technology, as a provider, we're going to be able to take that information and have it to be digestible and not overwhelming. And we're going to really be able to change the quality of life, not just those who have, let's say, terminal or chronic illnesses, but even young individuals who previously, continuous glucose monitors is the most game-changing things for young diabetics. And you went from pricking your finger, which is relatively terrible, to having to write stuff down, to now you're able to have, your friend, you can get an alert and say, oh, hey, your sugar is low, you should probably have something, instead of having that episode of hypoglycemia. So I think that whether it's somebody who's 72 with CHF, someone who's 14 with diabetes, or it's a pregnant woman, so she just doesn't have to go back and forth to her physician's office, and she can still go to work and have a relatively normal life while being pregnant and having hypertension. I think that it's truly limitless what we can end up doing with it.
Thank you, Beth. Appreciate you kicking us off there. Raj, what would you say?
I think it's similar to what Chris and Beth both alluded to. how do we make this seamless for our patients? How do we reduce the friction in adopting the technology and the support? And then how do we make that seamless for our provider and caregivers in supporting that? Because I think we're still, I think, all early yet. I think the technology is there. It's about how can it be deployed cross-platform, cross-disease state, that allows us to do that care coordination in a seamless fashion and to dose titrate too, right? That if someone's heart failure is better, maybe they don't need that daily, weekly check-in. Maybe it's more titrated down to decrease the burden on them in terms of monitoring. How do we simplify the information coming to our care teams to be just that, what's needed to direct the care? I think the example of the child with diabetes and that just-in-time notification, because I think also there's a lot of information that's been the challenge and the barrier for the adoption. It's more, do I want to know my patient's weight every day, or if it's increased a pound? When is it significant? And what's the mechanism by which we adjust their Lasix dose or adjust their medications to properly manage? We need all those pieces to be seamlessly integrated. And I think that's the nirvana. I think all of us are trying to work to make sure that care coordination happens seamlessly, and the patients also themselves feel like the technology is an ally to them and not more work. And it's easy for them to use and just part of their life, and not something extra additional that helps them get the best possible care and information to manage themselves. I think though that's the opportunity. Not quite there yet. I think we're still looking to what are those seamless platforms that help us, and those workflows that really make it easy to identify those patients who would benefit. But it's ongoing work in process. And I think it's exciting times. I think some of the burden also and burnout for our clinical teams has to do with just the amount of inundated information that they're getting. And I think helping them also prioritize and help direct the right feedback using their skills in the right way at the right time, I think can also decrease that burden, rather than feeling that they're being nickeled and dimed for every little thing.
Yeah, the support for them, and then achieving that seamlessness is when this truly becomes transformative, right? Thank you, Raj. Chris, what would you say about the potential here for these programs and this technology?
Yeah, I still think we're in an episodic mindset of healthcare, and we've got to get out of that mindset and get to a continuous health partner mindset. And I think remote care, whether it's monitoring or access to expertise or data points for my diabetes or whatever, is part of who I am, as opposed to something that I have to do every year or 6 months. And so it's the model change. We're not there yet, but it's going to come close. I mean, the other thing is decision support, call it AI, right? It took 3 years for Netflix to get 1 million users. It took ChatGPT 5 days. Think about how easy an adoption that is, right? And so we've got to learn from all other industries and apply that to how we have a model of care for health in the United States. That includes tools that I have on my phone. That includes access to expertise independent of your age, sex, gender, or LGBTQ status. We should be agnostic to all of that stuff. And I think remote care through our smartphones and enhanced technologies in a safe and secure way, allows us to do that. So I think we've got to change the mentality of healthcare. The problem is our model of healthcare is built upon episodic payment. And as we're still in episodic payments, the incent is not necessarily going to be there. We're going to need disruptors. And I think you see some of them here on the panel. They're starting to think about that stuff, to be those positive deviants, those disruptors in the industry, to allow us to think differently and actually allow us to better care for the patients that we're serving.
Thank you so much, Chris. Sandeep, what's your thoughts here?
Yeah, I think, based on what everyone just said, everything that they said is exactly right, right? That if you think of it as a patient-centric or caregiver-centric approach and think about the whole, not just when people are sick, but preventative care and wellness that are linked to everything that Chris just said, and connecting those dots, you need automation, you need some level of clinical rigor in terms of either FDA approval or peer-reviewed studies that show the effectiveness of how these tools are actually helping to scale access to care, reduce costs, and the shift from fee-for-service to value-based care models, I think, are some of the economic drivers that are going to make these type of tools more pervasive, right? And I think the challenges in terms of the opportunities there, it's going to be putting these pieces together in a way that's driving value for people like us. Like everyone's going to be a patient one day, right? So it's about that patient-centric approach and linking all of these tools so that they're seamless, right? To Chris's point, the shift from thinking of it as episodes of care, but looking at it as your whole care journey is from being well to preventative care to if you ever need acute services. But how all those pieces fit together, I think, is going to be the goal here.
Yeah, thank you, Sandeep. I've learned a lot throughout the course of this conversation. I'm going to tee up the final closing thoughts question this way. This is a big topic. So what haven't we gotten to that you think is important for our attendees watching this right now to understand, or what would you maybe like to re-emphasize before we sign off? Sandeep, I'm going to give you first crack at this one, then we'll go around to everyone else.
Yeah, like Raj said, right? Pick one area that you want to focus on. Get good at that area, and then start expanding, right? So you can understand and learn. And then to where Chris and their program is, now they're at the point where they're actually thinking about linking together some of these disparate areas, right? So I think the key is focus. Pick the area of care that you want to help support, and then expand from that.
Thank you, Sandeep. Chris, what would you say in terms of what do you want to add here we didn't get to, or what do you want to reemphasize?
Yeah, I think that it's not about the technology. It's about the people that we care for, the patients and the physicians and the nurses and the APPs out there. If you think about them first and you think about what you would need as a person who is a patient, we're all patients all the time, and ask, thought leaders outside of healthcare to think about that and partner with healthcare leaders, because we're better together in this space than we are there. I agree with you, the stepwise process, you got to, do step 1, step 2, step 3, but that's not going to disrupt. What's going to disrupt is us thinking about things differently. So if I got a secure texting platform, why aren't I using it with the patients? Why aren't I using it for this other thing? If I have an EMR, why is my patient just in there doing it themselves as opposed to me, right? And allowing us to think differently and, get out of those 4 walls that we've had and out of the traditional thinking. So, empower people to think differently.
Thank you, Chris. Raj, same question.
So I think also just thinking about communities that don't have digital technology, broadband access, Wi-Fi access, I think just how do we solve for that? Because I think as all of this accelerates, how do we support communities that don't have that, who don't have the technology and means or even a smartphone to be able to engage in this? So I think that's one area of opportunity for us. And then I think beyond even, I think in thinking of preventative health, and, I think all the ways that we're using data around nutrition, education, activity, exercise in really driving health outcomes rather than, disease state improvement. I think that's another potential frontier. I think a lot there. It also incites a little fear internally for the primary care inside of me, like how much additional can I take on or give feedback to? But it is important. I mean, those are the other things. How do we support the health and wellness of our populations that we care for? So I think there's an opportunity there longer term.
Thank you, Raj. And Beth.
I think I echo so much of today's conversation. I think looking at other industries and being able to leverage what they've learned from other industries and utilize that to help coordinate the patient care and to coordinate the patient experience. I never want to take away that a patient is a person, and their experience with the healthcare system, with their healthcare journey, is equally as important as me as the provider being able to give that. And I think being able to leverage technology, a little bit of AI, and really changing the way that we think, like Chris said, changing it from an episodic mindset to a health partnership. I am your partner. We're doing this together. I think is really going to be a game changer. And I look towards different ways that we can deliver care, especially in the virtual way, will really be able to enhance that.
Thank you, Beth. Great place to close. Thank you to all the panelists. Again, it was a fabulous conversation. I feel privileged to get to be a part of these. So much thanks to all of you. And of course, I want to thank Bioformis as well for helping Becker's put this together. To learn more about remote care, please check out the resources section on your webinar console and do fill out the post-webinar survey. We appreciate the feedback. Thank you for joining us. We hope you have a wonderful rest of your day.